Welcome, everybody. Dr. Jacob Rumley is going to be talking to us tonight about dural tears and meningoceles. Dr. Rumley, it is yours.
All right, thank you. Yeah, so nobody ever wants to be the dural tear and pseudomeningocele guy, but I'm now right out of a fellowship from Augusta University, working with John Devine, and there are a lot of revisions, a lot of complex cases there. So I certainly got my experience dealing with these, and I thought early on in a year it's good for especially new fellows to kind of get aware of these complications and kind of figure out how to manage them, because there's textbook chapters on it, nothing really follows the textbook. So here we go. See if I can get my slide to advance. Okay, quick overview. So incidental durotomies are what we're talking about, not any time that you're doing intradural work, but an unintentional injury to the dura happens anywhere from 1 to 17% of cases. So I think we can all agree 10% is a fair number to say is about the incidence of these. 8% of the recognized incidental durotomies can lead to a cutaneous fistula, which is certainly a pretty significant complication. There's some good literature out there that reviews the risk factors of these, especially one from Dr. Baker Spine 2018, said revision surgery is the #1 risk factor to have a incidental durotomy. But other things like age, the surgery type, whether it's MIS or open, the experience of the surgeon, OPL, diabetes, and more recently, previous steroid injections within 3 months have been associated with a incidental durotomy during surgery. But remember, it's not always our fault. So there's another thing that we like to forget about or not even learn about, and that's called a spontaneous dural tear. This can happen. Not all dural tears happen intraoperatively. We usually think we've injured the dura mater, but there are lots of case reports and case series about these blood patches being performed for people who have spontaneous hypotension that's due to dural leaks. And some have even postulated that some dural ectasias and things like that may be due to some dural tears that happen just from patients having thin dura in a non-confined space. What do we usually see when somebody has a dural tear that maybe we didn't recognize intraoperatively? It may be just postural headaches, maybe a palpable bulge like the patient in this photo. She has a little butterfly tattoo in her lower back that should be concave, but in her case is convex. They may just have low back pain, and at worst, you may see some cerebral spinal fluid draining from the wound. But just remember, the SPORT trial says that the only thing that patients with a incidental durotomy are going to have that's a negative side effect from that, if you repair it, is they're going to have an increased inpatient stay. So most patients do pretty well with a incidental durotomy as long as it's addressed. Something I think a lot of us don't think about and maybe didn't even know about until you see a patient with one is that they can have some progressive neurologic deficits. So there's been 7 case reports I was able to find that talk about these compressive pseudomenigoceles or CSF collections after surgery associated with a durotomy. Certainly the cervical ones are worse because they can lead to a quadriplegia, but it can be associated with a radiculitis or a cauda equina-like syndrome. Molinari published a paper about a year ago reviewing a couple of these, and in his review, there was a patient that had quadriplegia due to a pseudomeningocele that was pushing on the cord. And after decompression, they had complete resolution, and it took about 2 years for the patient to completely resolve. So a progressive neurologic deficit after surgery, if you've had a durotomy, you definitely need to consider that may be present. What do we do if we have an incidental durotomy? Well, the primary goal is to get a watertight closure at the time of surgery. The gold standard that everything in literature is compared to is a suture closure. Remember, that needs to be using some kind of closure device that the needle swedge and the suture are matched, so you're not causing little dural punctures that are not sealed throughout. And the technique is the technique that you've been taught, the one that you're comfortable with, and the one that you can perform safely. Now, there's been some question on, are fibrin glues a good additive? I think most of us use them. I certainly know in my training we did, but know that there's some of them have case reports that are associated with neurologic compromise after use. And one of those actually has a package insert that says that you should not place it over nerves and enclosed spaces. Yet we're using those to repair durotomies. There's another one that goes by a trade name of Tacil that is actually considered safe in humans, and I'm not picking on it, it's just an example, but it's actually human cryoprecipitate thrombin. So there's a question of whether or not you need to disclose that to patients that they're getting a non-autogenic tissue. Lastly, you can use fat grafting, allograft dura, fascia lata, which thankfully, due to some of these other products, we don't have to go to as often. But a collagen matrix has been shown to be the equivalent to that suture repair. And in Vora's paper where he showed using this technique, it's important to know that this was done in a very specific way. The collagen patch was placed over this tear, and he's showing an axillary tear, which is very hard to repair with suture, then placing a second layer on it to create a tamponade-like effect to fill that void, then a drain and a watertight closure. He does place a drain, and as a reminder, as I'm sure everybody is well aware, subfascial drains are 100% safe in these, as shown by Wang in 1998, or Wong, sorry. So other things that you can do, you can perform a xeroplasty of those muscle flaps to rotate them down into the defect, especially if you have a large laminectomy wound or a lot of scar tissue. You can perform a paraspinal release, as you see in figure C, where they've released those paraspinals to allow for a watertight fascial closure to withhold the cerebral spinal fluid. And lastly, consider putting a lumbar subarachnoid drain. You want to divert about 50% of that fluid so that you can protect your closure. And this is for a lumbar wound or a lumbar incidental durotomy. Cervical, it's a little different. You're not worried as much about that column of pressure pushing on it. I've certainly been approached by some representatives from the amnion world asking if they think that this would be an adjunct, and I was interested when they quoted the TLIF data showing that there's a decreased rate of dural adhesions after surgery. But remember that that does not equal a dural repair, preventing adhesions. So it may be quite the opposite. Some ENT literature shows that it's effective in skull-based surgery, and there has been some neurosurgery reports of using it in spinal surgeries for large defects. But in the end, there's really no evidence to support using amnion as an adjunct to your dural repairs. Postoperatively, after you've repaired this dura, what do you do? Well, there's some very good protocols that have been published to show exactly what you should probably do. And in this case, this is for a lumbar durotomy. If you have a patient with a cervical, you'd obviously want to keep the head of the bed up, elevated, so you don't have that fluid column compromising your repair. But it's a progressive, increased activity. This is just one protocol, and this is from the Kahn article. Everywhere should kind of have their own protocol that they follow. Make sure you're well aware of that. But in the end, the goal is if the patient can't get up and get walking within a couple of days, they're having continued spinal headaches, they're having symptoms, then you probably need to go in and do it again. And always close the fascia tightly, because if that can hold it, that may be the thing that gets your patient up and walking again, because they can form a pseudomeningocele. Pseudomeningoceles, it's a collection under the fascia. You've contained it. They're probably going to be able to do just fine. Though they are frequently asymptomatic, I put this cerebral spinal fluid foundation on there. They have one of the best mottos, because your dura matters. But this whole organization is based on patients who've had cerebral spinal fluid leaks and now are having pain and problems. They provide support and also litigation assistance. So, I certainly learned in my residency and training that most of the time a pseudomeningocele is not a problem, and it's probably the most common complication after spinal stenosis surgery from the SPORT trial. But when it matters, you got to know. So when do they matter? Well, if they get big. If they get big, they're probably going to matter. So a 8-centimeter pseudomeningocele, that's considered a giant pseudomeningocele. I don't think a lot of orthopedic spine surgeons have seen a lot of giant pseudomeningocele, but they've been reported. They've been around. We've known about them since 1946, but only 7 of them have been reported on in the literature. So if you do see it, what do you do? Nobody really knows. There's only 7 reported ones, so we don't exactly have an algorithm on how to treat these correctly. You're kind of on your own. And at that, 4 of those, which was reported by Solomon, that were asymptomatic, resolved on their own. The patients did fine. He watched them. They got better. They did fine. But these were asymptomatic. So we can't treat all of them like they're all asymptomatic, because according to Solomon article, they're going to get better. But what do you do with a patient who's got horrible cerebrospinal fluid headaches, has horrible back pain? Well, you have to think about what else could be going on. There's been reports that their arachnoid can slowly herniate out. Every time they have a Valsalva-like event, it pushes a little more CSF out. They develop a high-pressure pseudomeningocele, and eventually you can get a nerve root that herniates out. Those patients obviously are not going to be doing well, and watching them will probably not make them better. If they're not having those problems, or if you feel that it's too early to operate, they're not a good surgical candidate, consider doing things like placing a lumbar corset to try to decrease the volume expansion. You can watch them. Benign neglect is not maltreatment. It's not no treatment. It's just allowing the patient to realize that it's probably going to get better. I would follow them closely because they've had a postoperative complication, even though it's probably not one that's going to affect them negatively long-term. Keeping them close and making sure that they know you're going to take care of them and you care about them is, I think, the best way. And lastly, I, as an orthopedic spine surgeon, would certainly consider speaking with my neurosurgery colleagues about either placing a subarachnoid drain or VP shunt. So when it comes to surgical treatment of these, if they are symptomatic, if non-operative treatment hasn't worked, I'd say the first thing to do is load the boat. Try to get plastics involved. If you're an orthopedic surgeon, contact your neurosurgery colleagues, and vice versa. Because the more people you have involved, the more people you have charting, and the more ideas you get, likely the better you are to have a positive outcome. You can consider extirpation, which just means to excise the entire pseudomeningocele. You can take them to perform a revision dural repair. You can take the meningocele and pants over vest repair it and place a lumbar drain and VP shunt, or do all at the same time. So no single answer is probably the correct answer. Operative technique that we performed in fellowship, which I certainly think worked really well and probably makes the most sense and has been submitted for publication, is this technique that Dr. Bender, who's a neurosurgeon at Augusta University, kind of came up with and did really well. And I was honored to work with him and do one of these cases with him. And essentially what he did is he exposed the entire pseudomeningocele capsule, and he would use its hydrophobic tissue to kind of enclose this fluid. So we'd place some collagen matrix down, try to repair the dura, then pants over vest this to try to hold that fluid from getting too significant. Then lastly, because they have essentially a tissue expander in their back for these large giant pseudomeningoceles, we'd advance the muscle flaps and place a subfascial drain. So after you've done all that, you've done everything you can, you have 2 options. You start praying and hoping that it doesn't come back. When that fails, there's always alcohol. So thank you for letting me present that. And I'll go on to the first case unless anybody has any questions.
So this is a quick question. In your research that you've done, we had this kind of famous case of a difficult to diagnose spinal headache after a discectomy. I don't know if any of the LA or the San Francisco guys are on, but it was Steve Kerr, the coach of the Golden State Warriors, that eventually ended up going to Duke. It had some kind of eclectic neuroradiology diagnostic type myelogram that eventually diagnosed it. But we've all seen, fortunately rarely, a patient that they're really, you can't really find a leak, but they have the classic presentation of a post lumbar decompression dural headache. Did you come across that in your looking at the literature?
So when we this next case I'm going to present, we certainly talked to the patient about that exact case. You know, in the end, there's no single treatment that's probably going to work for everybody. I think it depends on the cause of the pseudomeningocele and why they have it and how advanced it is, and you know what step they're at. You know, one of the questions that's popped up online is asking if you would consider aspirating the cerebral spinal fluid, and that's certainly something that people have recommended and done. You know, but I think that once you get to the point where you have a giant pseudomeningocele or a chronic one, I think that you're to the point where neglect and less significant interventions typically aren't going to contain the fluid.
Jacob, we've got a couple of our neurosurgery partners watching
Yeah.
in here. Quasi Boa, do you have anything to add, or Tom Gianaris, anything to give us a little couple of pearls from the other side of the aisle? I don't know if they can get on.
Yeah, you know, one thing I think, at least at IU, what they did was they would leave the drains in for 7 days on these big ones.
Yeah.
And just let it drain, and kind of create a stable fistula and then suture over that. They didn't do it on all of them, but for ones that they weren't super satisfied with the closure, I think they found good results with that.
Thanks, Tom. All right, Jacob, hit them.
All right, this pop up now. Okay, so this patient was a 51-year-old female with left lower extremity radiculopathy. It was all S1 radic. She had 3 nerve root injections. They gave significant relief, but each time for less long. To the last one, she got the injection, only gave her 1 week of 100% improvement. She was otherwise healthy, but of course she was a administrator within the hospital system. So we know it's going to go bad. All right. So I'm trying to advance my slide. So on exam, she had positive straight leg raise. Everything was localizing to the L5S1 small disc herniation with S1 compression. So we took her for a discectomy, performed an L5S1 discectomy. During the surgery, we noted that her dura was just beyond thin. I mean, everybody's seen that thin glass-like dura. I mean, this was even more so, to the point where the other surgeon and myself spent a lot of time looking at it, convinced that there had to be some kind of small incidental durotomy. I mean, we stared at that for probably 15 minutes, but there was no CSF. We actually discussed whether or not we should put some collagen matrix patch over it just to be safe. Elected not to do it because we didn't have a durotomy that we saw. She left. She had 100% pain relief. The day 4, she called and said she had a sudden pull on her back, headache, and postural worsening. So we had to go to the emergency room. Unfortunately, this MRI was 10 days later because our emergency room elected to rule out a Berry aneurysm and send her home, and we couldn't get a hold of her because she was having a hard time getting up because she had such a severe headache. But then we finally got her in 10 days later, got this MRI, and we saw cerebral spinal fluid that had migrated past the level of the fascia. So we elected to take her for a revision dural repair exploration and IND. So there's axial cuts there. You can see that her dura is just certainly wavy appearing. I don't know a better way to say that, but it doesn't look taut as the dura should. So post-op day 10, took her back for a revision dural repair. We investigated it, looking for any sharp edges, things that we could have done that would have caused a durotomy. What was interesting is the durotomy was exactly in the center of our laminectomy or laminotomy. There was no bone up against it. I mean, positionally, obviously the dura moves a small amount, but it was very interesting that it was kind of in the center of where we were looking the entire time. So we performed a watertight closure with suture. And as we were doing that, the dura would tear with each suture pass. But, you know, by focusing, using good technique, we were able to get a watertight closure with the suture. We performed a good fascial closure. We put some adjunct fiber and glue on it, placed a subfascial drain, kept her laying flat for 24 hours. She did really well. In fact, she had zero pain, discharged home on post-op day 3 as she advanced through the protocol on no pain medications, feeling 100% well. And she called back a couple of days later, sudden low back pain and headache. So got another MRI, another dural repair. At this point, we're banging our heads against the wall, just giving ourselves a bloody nose. At that time, took her back, and where we had placed all of her sutures, she had torn around those prior sutures. So we got a revision repair with suture, placed a collagen patch, placed sealant over that, or a fibrin glue over that, rotated muscle flaps down into the defect to try to tamponade that area and provide compression, and placed a lumbar drain and left it in place for 7 days, as I previously stated would be a good idea. Fortunately, we followed that recommendation and kept her laying flat for 24 hours. On post-op day 12, we felt like we hit a home run because she was doing great. She was at home. We brought her back. We removed her sutures. She was on no pain medication. We just felt awesome. And if I was at Augusta, so of course, a hole-in-one was the obvious thing. And if anybody knows anything about Tony Finau, it didn't go well for him. Post-op day 15, she called. She had back pain. A month later, she called again. She had return of her spinal headaches. Got a repeat MRI at this time. Now it's a very large pseudomeningocele, still under 8 centimeters, so we're not a giant yet. So I guess we've technically won a little bit, but her wound is well healed. She's got back pain, a little bit of spinal headache. We actually spoke to her at length about the Warriors coach, how he had kind of some similar things, and we were, discussed, this could be other things going on. We were worried that maybe she was having some dural or some CSF balance problems at other areas. Maybe she had an intracranial process. Maybe it wasn't this. But in the end, she didn't want surgery, and we felt that we had probably done everything we could do with that last surgery. So we gave her a lumbar corset, and we told her, you're going to be okay. So at this point, now this is how her hole-in-one feels, okay? So anytime you think it's bad, because we're like, she's got horrible back pain, her CSF headaches got a little bit better, nothing ruins outcomes like follow-up. So 3 months later, she came in, she started to develop contralateral L5S1 radiculopathy, increasing mass over her low back pain, over her low back, despite wearing her corset. Her legs started giving away, and she presented to the ER with a fall. We found out about her legs giving away when she presented to the ER. So another MRI was obtained, and by now this thing is just beyond monstrous. I mean, it's over 8 centimeters in the cephalad 6 centimeters across. It's just a huge pseudomeningocele. So at this point, bad news doesn't get better with time, and a good plan now, or a bad plan now, is better than a really good plan too late. So we took her, and we performed that technique, which I had talked about previously. We exposed a capsule. We placed a collagen patch over the Dura, pants over vest on the pseudomeningocele. Because it was L5S1, we didn't have very good fascia to kind of do a paraspinal muscle release. So we had to do a rotational flap with her lumbar musculature down over that. Placed a drain over the fascia and kept her flat for 2 days. In the end, keeping her flat for 2 days, does that matter? Probably not. Keeping her flat for a week probably would have been best, but in 2 days she was doing well, and we felt we had a great closure. Our final outcome on her, the mass did not come back in her back. Her motor exam returned to completely normal, and she had complete resolution of her paresthesias to her feet and was able to return to work. So unfortunately, that was my my introduction to bad dural tears during my fellowship.
Jacob, that wasn't bad. That was like the worst I've ever seen.
I have to
that was the nightmare that kept coming back and coming back. Oh my God.
I have to thank John Devine for letting me operate on that patient initially. I mean, he obviously was there the whole time, but allowed me to manage the patient with him, and a very open dialogue the whole time, because I mean, man, I just wanted to slam my face against a wall most of the time, and she's the nicest lady in the world, and she's an administrator. should have known it was going to happen.
Of course. You know, it's interesting that you talked about how thin her Dura looked, because occasionally I'll do a case and me and the fellows are looking at the Dura and saying, whoa, that's really, really thin. And, you know, so translucent. It looks like it's, you know, a couple microns thick. And I wonder if there's, how prevalent it is. Maybe our neurosurgery buddies, Tom or Quasi, is there anything written about that? About the variation and the dural thickness? Because you did everything you should have done. You repaired them multiple times. You put the sutures in, she pulled through the sutures, you repaired that again. I mean, it becomes, you know, it's a no-win situation.
Yeah, I think just really poor protoplasm in her case probably contributed to it. And I mean, there were heroic efforts. I think what you did was great.
Now, Jacob, the only thing, you know, you had so many redos, I lost track of them. I mean, do you think maybe in the beginning, if you left her down for more than a couple of days, it would have made a difference? I mean, who knows?
Yeah,
you have no way of knowing.
Well, anytime you have a horrible complication, you go back and relive that every time you think about it. And I pull this case up, unfortunately, every time I'm exposed to a medical student or a fellow. And so I relive it and I question everything I did every time. But, you know, in the end, I think that at least we followed a stepwise graded and we increased the invasiveness with every surgery and just didn't try to do the same thing every time. And I think that's one of the key learning points for me that fortunately Dr. Devine taught me.
Did you do a subarachnoid drain each time? And at any point were they thinking about doing a peritoneal shunt?
Yeah, so we discussed the peritoneal shunt with the neurosurgeons. We placed the subarachnoid drain 2 of those times. And each time we kept it in place for 7 days. You know, by removing half the CSF volume and keeping her flat, I think that would have helped. But what was interesting is I think she did have a lot of CSF that was extruding, but I don't even know if that would have allowed it to heal. I think in the end, you know, if we could have kept this under her fascia, and I think that we close fascia pretty well, I'm sure everybody does. You know, I think she may have done better, but, you know, with that last one, interestingly, she developed what almost acted like a nerve root herniation, where she suddenly had significant contralateral radiculopathy. And I didn't put it in the talk, but she said she had a cough the week before and had been coughing a lot. So, you know, I don't know. I just hope I never see that again.
Did you do, how'd you close the fascia? Did you do running suture? Did you lock sutures? What did you do to try to make it watertight?
Yeah, so we did a figure of 8 with a absorbing suture, number 1 Vicryl, then backed it up with a running PDS over it and locking that. Yeah. So everything.
There were a couple questions from the chat. Would you consider aspirating the CSF?
Yeah, I think that's an option, and it's been discussed, and there's some reports of doing that in literature where actually patients they'll place a or I guess it's technically subarachnoid. It depends on what layers are in your pseudomeningocele, but actually just placing a diverting drain or placing a BP shunt has been shown to help with that. You know, it's something we discussed, but you know, in the end, it's a very orthopedic mentality, I think, of something's broke, fix it. And, you know, if they have, you know, a problem with their Dura, instead of just diverting, in this case, our goal was just to try to get it to close. So.
I had one question. Has anyone used blood patches via IR for these with just continued headaches?
I mean, I've used it on occasion, Tom, not often. You know, you always worry about compressing the thecal sac too much.
There's no blood patch that's going to solve a tear like this one.
Yeah.
Yeah,
No.
really not for surgical. I mean, obviously for post-myelogram headaches, blood patches work, but for a surgical tear, they typically do not. And Jacob, one of the things, and maybe I missed it, that you didn't mention, and maybe you did, it's the collagen thing, is the Duragen, the little patch that just kind of sticks on the dural tear.
Yeah, yes, sir. That's what we were using. I was trying not to use trade names.
Okay, but that's a collagen. Okay.
Yeah. The collagen patch was Duragen. The fibrin glue was Duracell. So.
Okay. All right.
And
Thanks.
Jacob, it's one of those things, hindsight is always best. So you were describing when the first time you went in, you didn't see a dural tear, you're thinking about putting the Duragen on, probably should have put it on, and maybe you wouldn't have had this case.
Listen, if I learned nothing else from this case from the beginning, I am going to be the most like Duragen, like that looks thin, slap it down. I mean, in the end, would it have stopped it though? I don't know.
Yeah,
Well,
it's interesting because we've all seen, when you get that outer layer of the dura that gets thin and you see that little bleb of, I don't know whether it's pia or subarachnoid, but it's not leaking, but it's definitely the outer layer is torn. Always throw Duragen on that. And I used to always have this rule, and Heisey, who's on, Dr. Heisey, will remember from training and stuff, is the 2 out of 3 rule. Watertight closure, a sealant, or a subarachnoid drain. I try to get 2 out of 3. If you can't get a watertight seal, do the other 2.
So and the other rule, Jacob, is if you think about it, do it.
Yeah, absolutely. So, and there's actually a good question from the chat that asks, I'd like to know everybody's opinions. Does everybody use subfascial drains? And if you do you leave it on suction, off suction, 24 hours, longer? What does everybody do?
Well, I won't put suction on them. Subfascial, no suction for 24 hours, then we pull it.
Okay.
Yes, the article that you cited, when I first went in training and started beginning my practice, it was considered contraindication to use a drain with a dural tear. Then the article you cited said that, no, that's not a contraindication. But yeah, I agree with Rick, just with no suction.
Yeah. All right, Clay, do you want to present
Absolutely.
the case?
Clay, you have big shoes to fill.
Well, fortunately or unfortunately, my cases aren't as exciting as Dr. Rumley's were. But
I've really inherited quite the dural tear referral practice to this location, so it's been great.
So my name's Clay Dornkamp. I'm the fellow at Center for Spine and Orthopedics, Dr. Rumley and Dr. Jansen this year. And thank you guys for having me on these talks. This is a great learning experience for us fellows. So both of these cases are actually cases that came from a community surgeon that's not in our practice, and Dr. Rumley is now helping manage post-operatively, but I think they both offer good learning experiences, especially for people like myself who are in the early aspects of their training and their careers. So the first case is JS. He's a 48-year-old male, and his overall complaint that brought him onto this talk was a, quote, swelling in the back of my neck. So his story started back in January 2018 when he presented for neck and right upper extremity pain that for the last several months. He had no signs of myelopathy, and his exam showed good strength and good sensation. So his x-rays show pathology at C5-6 and 6-7 and degeneration, and his MRI shows compression at those levels as well. So ultimately, this patient underwent ACDF without complications. So post-operative, the patient recovered without issue, his symptoms being overall improved. His only complaint at 3-month follow-up was that he had some posterior cervical pain, but was overall very happy with his surgical outcome. So approximately 1 year later, the patient presented with increased headaches and bilateral ring and small finger numbness. That one confounding factor in his history that it was worse when holding a video controller, which makes us suspicious of more cubital tunnel syndrome than cervical spine issue. But an MRI was performed showing bilateral foraminal stenosis at C5-6 and C6-7 and concern for radiculopathy versus cubital tunnel. An EMG was ordered and it showed a left C7 radic with normal ulnar nerves bilaterally. So the plan at this point was a bilateral C7 nerve root injections, which did provide relief, and the patient was scheduled for a bilateral C6-7 foraminotomy. These were his x-rays at 1 year post-op showing subsidence of the cages. But overall, I think he did achieve union. This was his MRI at that point. I don't think the axial that I captured does a good job showing the bilateral foraminal stenosis. So he ultimately underwent a bilateral C6-7 foraminotomy. The technique that was reported in the op note was a high-speed burr was used, and a kerrison was used to make a keyhole foraminotomy on the left. They did note a small dural tear with a CSF leak, and the dural tear was repaired with a dural patch and fibrin glue, and no stitches were noted to be used in the operative note. Attention was then turned to the right side, and a right-sided foraminotomy was performed without incident. The wound was then closed in a layered fashion. So the patient at this point was kept upright for 48 hours. He had intermittent positional headaches while he was in the hospital, and he was discharged. 3 weeks post-op, the patient called with worsening headaches and had noted a bulge posteriorly around his incision. An urgent MRI was ordered and showed a 6x6 fluid collection consistent with CSF. Thankfully, this patient continued to be neurologically intact, but he did have worsening headaches at this point. And there was a palpable bulge along his posterior incision. So this was his urgent MRI that was ordered, showing a large CSF collection along the posterior spine and under the subcutaneous layers. So this patient ultimately underwent a revision dural repair. When they made incision, CSF was noted immediately after incision. Dissection was carried down to the foraminotomy site bilaterally, and a laminotomy at the C6 and C7 vertebra was made where the persistent dural tear was identified. This time, 2 sutures were then placed into the edges of the dura and was repaired with a collagen patch and fibrin glue. So 2 weeks post-op, his headaches were improving, and he was continued with upright positioning for an additional 5 days and instructed to call if he had worsening symptoms. 4 weeks, he continued to do good, and we are currently at 6-month follow-up with no recurrence of headaches or bulging of the incision. So that was that case. If anybody has any comments or...
So that was an old style open approach for foraminotomy, I take it.
Yes.
Yes, it was.
Yeah.
Yeah, that's. I think what I take from this is, if you have a durotomy intraoperatively, address it the first time. Just spraying. I think that placing some fibrin glue over it is not the wrong answer, but I think you actually have to assess your durotomy, and essentially what was reported is it sounds like it was where the dura gets caught by the edge of the drill, and it's not in your direct line of view. So instead of performing a larger laminotomy, identifying it, assessing how big that tear is, it was spraying some fibrin glue on it and watching. But, I'm not throwing stones. I wasn't there, but I think that's probably what I would have done a little differently.
So you think the take-home lesson is enlarge your laminotomy and define it and see if it's repairable rather than trying to stuff something and get out of Dodge?
Yeah, I think that's fair.
I think that's okay if they were doing it through the tube and the muscles would just form over it. But once you do an open, then you have all that dead space.
Absolutely. Absolutely. All right. Then there's no other questions or comments. Clay, why don't you bring up the last one, which is probably one of the more interesting ones.
Yep. So this was TK. She's a 60-year-old female who presented to the outside surgeon with low back pain and left lower extremity weakness. She's a 60-year-old female who was a personal trainer and bodybuilder, a professional trainer and bodybuilder. She had low back pain and increasing left lower extremity pain that radiated to her foot. She had subjective weakness in her left lower extremity and difficulty with ambulation, as well as loss of balance. Pain increases with coughing and sneezing, and she has failed non-operative modalities at this point. As far as her physical exam went, her sensation was normal. She did have weakness in her tibialis anterior, which was graded as 3 out of 5, but overall global weakness of the left lower extremity was noted. She did have a positive straight leg raise on the left and 2 out of 4 reflexes. This was her APN lateral x-rays. And then moving on to her MRI showing a left paracentral disc herniation. So the plan for this was a left L4-5 microdiscectomy and foraminotomy. At this point, the patient underwent an uncomplicated left 4-5 microdisc and foraminotomy and no reported complications. 10 days post-op, the pain in her left lower extremity had significantly improved and was starting to walk on a treadmill with less pain. She still complained of some residual weakness with ankle dorsiflexion and numbness in the left lower extremity, and the patient was given a Medrol dose pack for residual symptoms. At 6 weeks, her numbness and tingling was much improved on her left foot, and her strength was getting much better. And she was very satisfied with her surgical outcome. And at this point, she was planning to return to normal activities and to gradually reintroduce her weight training programs. So at 2 months postoperatively, so two weeks after this visit, she had had 1 week of worsening numbness and tingling of her left foot. She had weakness in her left foot again, and no relief with tramadol, robaxin, gabapentin, or Medrol dose pack. On motor exam, her tibialis anterior and EHL and gastroc were now becoming weak again. Her MRI demonstrated a recurrent left paracentral disc extrusion that was displacing the nerve roots, and evidence of scar tissue throughout the left epidural space surrounding the L5 nerve root. And she was diagnosed with a recurrent L4-5 herniation and planned to have a left revision microdiscectomy at that point. So this is her MRI showing the repeat disc herniation. So at this procedure, she had a left lumbar foraminotomy and discectomy at L4-5, the revision left-sided dissection and laminectomy with a high-speed burr and Kerasins. A revision foraminotomy was performed, and then the microscope was brought in, and the recurrent herniation as well as scar tissue was removed. At this point, a dural tear was noted with herniation of the nerve roots. It was noted that a suture repair was attempted, but they could not obtain a watertight closure, and a collagen patch and fibrin glue was then placed to attempt to seal the dural tear. And then it was reported in the operative note that no CSF was noted after the closure. So immediately postoperatively, the patient was kept with the head of the bed at 0 degrees for 24 hours. She did have some minor positional headaches. She was noted to be 2 out of 5 with her dorsiflexion on postoperative day 1, so now with significant tibialis anterior weakness, but 5 out of 5 in her other muscle groups. 2 weeks post-op, she had no further headaches, but she was now complaining of new pain in her left buttock, down her leg, into the entire left lower extremity and foot. She had worsening strength in her left lower extremity. She did not have any bowel or bladder symptoms, and now she had strength graded as 3 out of 5 in her tibialis anterior and EHL, and weak hip flexors as well. And she had lost sensation to light touch at her outer left ankle and outer thigh and buttock. So the plan at this point was continued to use a walker and avoid falls, pain control, and close observation. And
Do you agree with that plan on a patient who's losing motor function?
No, and we actually had discussed that, whether an MRI should have been, further diagnostic studies should have been done earlier.
Or just a repeat operation. Yeah, I mean, once again, my goal with these is to learn from them and to not throw stones, at the prior surgeon. But there are a couple of things that were interesting. I don't know what the protocols are for any of the senior surgeons on, but typically within 6 weeks, I don't know if I would have gotten a MRI, because I don't know that I can reliably say it's not hematoma or scar tissue, but they went in and they apparently saw a repeat herniation, but then had this large dural tear, but they didn't use any suture again to repair it. It was just fibrin glue sprayed into what sounds like a pretty large dural tear. So I got involved right after this MRI was obtained is when my involvement came, which was interesting.
All right, so let me ask a couple questions. Just a great question on the chat of why not a TLIF. Now, there's a couple issues. Now, at 2 weeks, every MRI scan looks like a recurrent disc herniation.
Yes.
So number one, is surgery indicated right away as opposed to a trial of non-surgical treatment, because it wasn't a massive reherniation, which is pretty obvious on an MRI. But yeah, it looks like a reherniation, but they all do. And then what about the reflex of, oh, it's a recurrent herniation, I'm going to do a fusion? I think that needs to be discussed. Everybody. I mean, you do a TLIF, and instead of a small dural tear, you get a big dural tear. I mean, I I don't see the indication for a fusion on a recurrent disc herniation that happens almost immediately post-op. That just seems like a reflex that we're too much programmed into.
Especially when even surgery is a question. And, that was my point, is like, I don't even know if I would have gotten an MRI at that point. I don't know that surgery is indicated for an acute radiculopathy, so.
Well, we talk about that all the time. I talk about with the fellows. I said, look, if someone has leg pain after a discectomy, manage them non-surgically, because if you actually do a study like an MRI, it's going to make you want to go back in, because they all look like that.
And just to elaborate what Scott said, we always counsel our patients saying that, at the time of surgery, your body releases a lot of cortisol from your adrenal glands, and that makes you feel good all over. When it finally subsides or diminishes, then the sciatica or the inflammation of the nerve comes back. So give them a Medrol dose pack. Don't jump in and do surgery. And I agree. I try to do anything but get another MRI scan unless there's something catastrophic, because they always look like a recurrent herniated disc. And the patients ask, well, why don't you do an MRI scan? I said, do you want another operation? Because it's going to show that or look like you have a recurrent disc when you may not.
Rick and Scott, for just pain or a little numbness, I don't disagree with you, but you got somebody who had grade 5 motors and now is coming back and they've dropped down to grade 3. So I think you got somebody with progressive motor loss that you've operated on. And I don't know that you can just put your arm around that patient and not study the canal.
Okay,
well,
so given that circumstance, would you go ahead and just reflexly do a fusion at 2 to 4 weeks post-op?
I agree with you, Scott. I agree. It depends what the pathology is. Obviously, if you destabilize the segment and now you got a grade 2 spondy that you didn't have before and a pars fracture because you took too much of the lamina out, that's a different story. But for just a recurrent disc herniation, I would say no. And the other comment is I agree that it looks like a bomb went off if you get an acute post-op MRI, but that's kind of where you start, and because if you see clear pathology, then you have a pretty good idea what you need to do, and you can always get a myelo CT if you need it. But I think that's just the easier test to get right off the bat, understanding that it's not going to be a normal looking canal.
No, Jack, you made a good point. I was under the assumption that the deficit didn't start until after the second revision. And, certainly for the fellows, if somebody has, increasing neurologic deficit, you don't sit on them. You have to do an MRI scan. You have to investigate them.
But would you do that even if it's a 4 out of 5 EHL that's pretty stable? If the patient has a complete drop foot or something like that immediately post-op, but, decreased motor strength still, would you chalk that up?
No, and EHL wouldn't push me,
right.
but a tibialis anterior would.
Yeah. Okay. Perfect.
Yeah, I agree with you. It'd have to be a pretty remarkable neurologic loss, not a 4 out of 5. Drop foot, yes. 4 out of 5, probably no.
Very good.
Great discussion on this one, because this is something that everybody sees, particularly the fellows that are just starting this year. This is something you'll see all the time, and you can kind of adjust your barometer as to how much redo surgery you want to do based on whether you're going to get an MRI scan real early in the post-op course, as opposed to, hey, we just need to calm this down with a Medrol dose pack or some gabapentin.
Yeah, that's great. Great discussion. Thank you for everybody's input. There were a couple more slides that this patient had.
It gets worse.
Yeah, it's there's more to this story. So now we're at 4 weeks post-op revision surgery, and now the patient is complaining of saddle anesthesia, worsening neurologic function, and so a repeat MRI with and without contrast was obtained. And as we go through the MRI, it's showing that we're having clumping of our nerve roots and more scar tissue forming. So fortunately, this is about the time that Dr. Rumley and I were involved in the case. We saw her back to review the MRI, and she's miraculously getting better. Her strength is improving. She's now having days free of pain in her legs, and her saddle anesthesia is improving. So Dr. Rumley and I talked about this case quite extensively, and with her symptoms at 4 weeks, when she was having pain with excursion of her leg and the saddle anesthesia and some bowel and bladder issues, this was becoming to consistent with arachnoiditis, which we were talking whether having fibrin glue directly exposed to the neural elements may have had some role in that.
Yeah, I didn't know if anybody had seen this before in their practice where, because arachnoiditis being kind of a loss of the fluidity of your nerves with, due to swelling of the arachnoid. If you guys think that fibrin glue injected into the intrathecal space could cause an arachnoiditis, because amazingly, the patient came in, I got that MRI, I saw her on the exam, I said, holy crap, I think she's got arachnoiditis. And she came back and she said, about a month and a half later, I'm feeling great. And she still has some urologic symptoms, which she's now seeing a urogynecologist or to be evaluated for, just because I don't think I can help her. I think I can make her different. So I didn't know if anybody had seen that or had heard that. I looked it up. I wasn't able to find anything, but I figure if anybody has heard of that, it'd be some of the people on this tonight.
Jacob, I've seen the arachnoiditis after having the dural tears in a couple of my patients. Again, not symptomatic, but I look and I go, holy smokes, what the hell? And then I say, oh, we repaired the dura, and maybe a little blood gets in there. I don't know. Tom, do you have any comments? Or Quasi? No?
Yeah, I think that they used to occasionally do to seal injections for some of these post-operative like spinal cord stimulator patients and some of these more functional patients. And yeah, you definitely see arachnoiditis from that. And blood irritation too. Not even necessarily inside the thecal sac, but just, epidurally too.
The ones we see from multiple spine surgeries, they usually don't get better. Once the roots clump together and disperse, there's usually no turning back. So it's interesting that you got a resolution of symptoms. It'd be interesting to get an MRI down the line and see whether the roots are back in normal position. Maybe this was an acute inflammatory arachnoiditis, a chemical reaction that got better. But
you better believe I'm going to do that.
Yeah. It'd make another nice extra slide on the top.
Well, I hope to never give this talk again. I don't want to relive these cases over and over.
You guys did a great job. It was really, really good cases, good discussion.
Yeah, fantastic.
Yeah.
Well, Jacob, so will you give us your address? Can you flash it on the screen with the number? So if we get into these complicated cases, we will buy a ticket directly to Denver.
Just put it up on a billboard. Yeah.
I believe the first thing I said is I am not the Durotomy Pseudomeningocelen guy. I think the neurosurgeons are better at this than I am. All right.
Anybody else have anything to add or any questions from the chat group?
No, we just had a lot of good comments on the chat group about agreeing that that fibrin glue probably contributes to it, and with the arachnoiditis and such. So,
well, Jack, just one more thing, because we have a few more minutes. We used to have these little dural clips years ago that we got introduced by some of the neurosurgeons, and they disappeared, but they were the easiest way to repair a dura without, clumping it over and making it tight. Now, sometimes they'd come off, so that's a bad thing, but they were still very easy to repair. And I don't know if they have any variation of the theme that's out still. Tom, do they have anything like that still?
Yeah, those wet clips are great, and occasionally if there's a full nerve root avulsion, you can put an aneurysm clip on there and it'll hold.
Well, we orthopods don't want to be pulling those nerve roots out.
yeah. But those little wet clips, they work great, especially higher in the C-spine.
And Dr. Vela said those come off a lot.
Yeah.
That's what one of our other neuro partners said, that when he was doing his fellowship in New York, that he would be revising one of the attendings who used the clips and have to go back in and sew the tears because they would come out. But like Rick said, and this is probably 15 years ago, we were using these clips from, I forgot the company, and they actually did hold. I don't remember the company, but they really worked.
They were
like
well. Little C clamps, little tiny
like
C
little
clamps.
small vascular clamps that just it was the easiest way to close the dura, and they didn't come off. But I don't know about the current.
And they'd work good through a tube, for endoscopic surgery. So I'm surprised they haven't made a reappearance.
Yeah.
Yeah.
Well, super job, guys. We had a lot of participation, and tell Mike we didn't need him.
Yeah.
I just texted him.
That's great.
No, great job. This is really interesting.
Yeah,
Thank
Jacob,
you.
great. And, you know, a lot of lessons to be learned.
Absolutely, sir. All right. Well, thank you.
Thanks, everybody. Have a good one, and
Have a good
get
night,
your
everybody.
get your CMEs. All
Have a
right.
good one.
Great
All
job.
right, good night.
Bye-bye.
Thanks for watching. Hit the subscribe button for more medical content.